they may be lead to a further brain damage and go for a vegetative state. So what is consciousness? Then only we know the unconscious state. Conscious is a state of awareness of self and the environment. Okay, this is a conscious state. So this has two levels. One is arousal, that is awake. So this will decide about the level of consciousness, and awareness, that is the content of consciousness. So these are dependent upon the both physiological as well as anatomical system. So the patient may be arousable but may not be having an awareness, or the patient is fully awake but patient is not aware of the entire environment, may be there. Okay, so they are called as various categories, starting from altered sensorium, drowsy, stupor, and then it goes for coma. So what are the neuroanatomical basis for the coma? So arousal and awake, the level of consciousness. So it all depends on the midline structures. Okay, what we called as upper pons, midbrain, hypothalamus, and thalamus. If there is any issues in this area, okay, so this patients will go for a change in the arousal state or awake state. So this arousal, as I already told you, there are various stages are there. The grading, we are doing a grading. So first it may be an inattentiveness. Okay, they will be they will be looking you. They will not have any kind of alertness or attentiveness. Okay, then they go for stupor, abundant, drowsy, and then coma. Okay. So, as I already told you, this has both anatomy as well as physiological component. So, the awareness is the content of consciousness. This is mainly depend on the neuronal activity in the hemisphere. Okay, just imagine this is a cerebral cortex. I just want to explain this in detail because this will help you out to understand the cause of coma. Then we can easily point it out. The localization can be done with the proper neuroanatomy. This is a cerebral cortex and this is a thalamus, midbrain and pons. This all lies in the central, okay, central structures. So if there is a arousal to awake, there is a level of consciousness, this will be on the center part, pons, midbrain and your thalamus. Okay. And if it is an awareness, that is a content of consciousness, this will start ascending from your thalamus to the cerebral cortex. So this is a basic of neuroanatomy. With this background, we will just move on to what is coma. Coma is nothing but a state of reduced alertness, okay, and the responsiveness where the patient cannot be aroused. Patient will be lying just like a simple thing and he will not be able to move, or even if they are moving, it is not a purposeful movement. So whenever there is a failure of reticular activating system, that is a central structure system, okay, then this will cause a diffuse bilateral hemisphere uh, damage, or it may be both can be there. As previously I told you about the central system. So it starts with pons, midbrain, thalamus, and then cerebral hemisphere. Okay, if there is both cerebral hemisphere as well as your reticular activating system, both are get damaged, then the patient will be in comatose. Okay, so what are the causes for coma or any neurological? There is even seizures. We have used this mnemonic AEO and tips. Okay, this is a vowels with the tips. Okay, AES stands for any neuroabscess, acidosis, alcohol. E stands for epilepsy, seizure disorder, or patient can be in a heat stroke or maybe in a hypothermia, environmental, endocrine, electrolyte, that is hyponatremia can be there, and any encephalopathy. It's maybe a metabolic encephalopathy, or it may be a hypertension encephalopathy, or it may be hepatic encephalopathy, or it may be a toxic encephalopathy, any one encephalopathy. Infections. And when there is a patient is in hypoxia, or the patient is in uremia, or patients having some kind of trauma, head injury, or the patient is having some temperature dysregulation, as I already told you, hypo or hyperthermia, or any other toxins which penetrate the blood-brain barrier, patients can have a increased ICP or hypoglycemia, that is insulin-related factor, psychogenic or shock. Even hypoperfusion can cause a coma, as the patient is not having enough blood flow to perfuse the brain. As you well know, the brain gets the energy from the supply of blood supply, through which the oxygen and glucose are carried away. When there is an hypoglycemia or shock or hypoxia, the blood will not, adequate energy will not reach the brain, by which the brain will be in the disactivated way. We ultimately land to coma. So this can be again classified into supratentorial lesion or infratentorial. Supratentorial reason of causing coma, or it may be a common diffuse disease or increased intracranial pressure, or the patient can go for a herniation. Whereas infratentorial lesion, that is, it involves only the reticular activating system, it usually associated with the brain cells. Metabolic, again, if you see the metabolic cause, the patient will have a hemispheric involvement, and there will be a depression of reticular activating system. There will not have any focal finding. So the localization easily can be done that the patient is a metabolic cause of coma is there. And then the last comes a psychogen. Please remember that coma is a life-threatening situation. So you need to be very cautious in handling this patient, and you have to treat it as a medical emergency. So approach to coma patients. What are the priorities as an emergency physician? As an emergency physician, my mantras are again airway, breathing, circulation. So I have to stabilize the airway, breathing, and circulation. Once this step is over, then I should ensure that the patient is adequately getting oxygenation. And as I already told you before, the brain gets the energy by the blood flow, by through which the oxygen and glucose are getting. Same thing, we have to confirm it that the blood substrate reaches the brain and the vital organs. And we need to correct any immediate metabolic disturbances, blood glucose level, and if the patient is alcoholic, then we can start with thiamine, okay, to stop the vernix encephalopathy. So you may know that a Wernicke encephalopathy can be an MCQ question or a short notes, but really, mostly in weekends, we used to get full alcoholic patients, a pinch of alcohol, or just they come, they will all have a signs of Wernicke encephalopathy unless we are not failed to treat with the thiamine. So must always you have to address any life-threatening conditions before the CNS. Because CNS conditions we can monitor and then we can prevent further. But at the same time, we need to be very cautious. We need to know what are the preventable causes and immediately treatable causes. And these coma patients are more prone to develop seizures, and temperature dysregulations can occur. So both has to be addressed, and then the seizure has to be controlled. Because single seizure that after this coma, once the patient entering into the emergency room, and then the patient is throwing convulsion, it means that the brain is not adequately protected. And single seizures, again, it causes the brain damage and ICP increases, further decreases the cerebral blood flow, and then this produces the bad outcome. So unless you are very clear that the patient is taken isolated benzodiazepine or isolated opiate, then you can use the antidote like flumazenil or naloxone. Otherwise, no. In the olden textbook, they advise that in a coma patients, they advise for a coma cocktail. The coma cocktail is nothing but it contains 25% dextrose, it contains naloxone 0.2 milligram, and it contains thiamine. Okay. Now we know that the blood sugar can be easily measured and the history can be obtained whether they are the narcotic dependent, opioid dependent, or otherwise just they are taken for the first time, by which we can able to tailor our initial management in the emergency room. Flumazenil is given only when the patient has taken pure diazepam or benzodiazepine dose, then we can consider flumazenil. Otherwise, flumazenil itself can worsen the condition. So, well, as you well know, we are going to start our journey. Come with me. Once the patient is there, we have to evaluate the airway. So, airway is the first and primemost area where we need to focus. So, when the patient moves the air without any obstruction, it means that there is a patent airway. And you have to look for any trauma, foreign body that can obstruct the airway. Always in a trauma patient or an unconsciousness fall, you have to do a jaw thrust, intubate, and then get a spine clearance. Then only you should remove the Philadelphia collar. Though it is very difficult to intubate with the patient with the collar, we can use a video, either video scope or bronchoscope can be used just to intubate this patient. Okay. So when the patient is able to tolerate the oral airway, please remember that just by bringing our finger to a inner mouth, we are getting a nauseating or vomiting. In such a situation, we are trying a big tube of 8.5 with an oral protector or a pharyngeal airway. We are inserting it. Okay, so this will posteriorly trigger the vomiting. So whenever you are putting an airway, okay, it is very important that the patient has to be sedated and then ventilated. Once you are in the weaning phase and able to wean, then you remove the oral airway. Okay, and if the patient is not able to intubate, cannot ventilate, cannot intubate. This is called a CVCA situation, where that kind of situation we can use a Fuji. Okay, I'll come to it. So moving to breathing. So it is a very important area where we should not have any confusion between a patent airway and inadequate breathing, or inadequate airway and patent breathing. This is entirely different, but the management goes hand in hand. So, what are the things you see in this victim in a coma patient? We look for respiratory rate and do an ABG, look for the gas exchange, breath sounds are adequate, or whether it is equal, or is there any changes there. And percussion we can do to rule out the pneumothorax. And by auscultating, good auscultation, we can able to identify whether the patient is having a pneumothorax or the patient is having certain heart problem. Okay, we can just do that and always ensure that the patient should get an adequate oxygenation. And in case of type 2 respiratory failure causing coma, we have to adequately ventilate the patient. Okay. And a very important thing, if you are not intubated, okay, patient in the emergency room, because when we are stamping it as a coma, the airway will be roughly around 8 to 10, okay, not more than 10. Okay. In that condition, we can wait and watch. If it is 9 or 10, then we have to intubate this patient. Okay. So we have to identify the immediate life-threatening problems whichever are there in the patient. We have to address them, like police catheter, rise tube feeding, head bath, and such on. Okay, and you can tell the attenders and the relatives that the patient is on ventilator and the patient is slowly can improve. So that is an immediate thing what you need to tell. So once you intubate this patient, it is an added advantage. Though we put a mask, we can able to smell a different smell from the patient. Okay, it may be an alcohol smell, or it may be an acetic acid smell, or it may be some kind of infectious smell. Whatever may be, we can able to identify the smell. In a circulation, we need to know whether the patient is in shock or the patient is not. So always check the pulse, heart rate, and then perfusion. Okay. If you want to think that the patient is having an hypotension, shock, that is a very, very late sign. Okay. So do not restrict the fluid in the comatose patient, saying that patient can develop a cerebral edema, just giving a la carte of fluids and waiting for it. You no need. So look for the adequate vascular volume. If the vascular volume is inadequate, don't hesitate. Just resuscitate the patient with an IV fluid, just like that, anything. And an important thing, as I already told you in the previous class, patients should not receive any hypotonic solutions like a dextrose containing fluid should not be given because this will increase the fluid. So now after A, B, C, now we move on to D. So in a disability, you have to check for the GCS. GCS has a three component. It is one is eye, another one is movement, another one is verbal command. So based on this three command, okay, if the patient is intubated, we cannot able to identify the verbal component. If the patient is underwent some cataract surgery or some eye surgery, again the eye component cannot be assessed. Just by doing assessing the motor component, we can able to know whether you can able to prognosticate the patient. And after GCS, look for any paucity of the movement. If there is a left side weakness or a right side weakness, or if the patient is having upper limb weakness or a lower limb weakness, like that we can able to categorize just by looking for any movement after a pain. Look for the pupil. Pupil may be a normal or it may be pinpoint, dilated, asymmetry, or it may be reacting, non-reacting. That kind of things will give you a clue what to do. And once the disability is assessed, you have to expose the patient. Most of the time, by doing good exposure, we can able to find out other problems. Recently, we had a patient was treated in another corporate hospital in Europe. Suddenly became unconsciousness. History is patient is having some kind of fever, treated with an ceftriaxone, and it was not responding. Then the patient became unconscious and started breathing very fast. So they came to our hospital. Patient was intubated. Just on doing an exposure, I am able to see an SR. So by seeing an SR, we started on doxycycline. This is scrub typhus. Okay, and doing a proper exposure, we can identify is there any surgical scar, any obvious injuries, other obvious injuries, any petechiae, purpuras, spotting, is there any needle track in a patient who is an unconscious, having multiple needle puncture, it gives you the patient is have taken a drag, and so that we can try with a shot of naloxone. So very important is after E, look for the vitals. Okay, 3G. One is ECG, another one is ABG, another one is your CBG. So sugar level, we can go with a sugar glucometer. In the ABG, we can able to identify what is the electrolytes, whether the patient is hypoxic or not, whether the perfusion is good by looking the lactate level. And then in an ECG, this will give you a clue whether the rhythm is a normal sinus rhythm or it is an abnormal rhythm. So once this has been done, the other assessment of coma is based on getting clues from the attendants. Okay. Remember that most of the time these attendants are not the exact bystanders during this incident. They will be volunteer themselves and try to say some stories of their own. Okay, this should be taken in a pinch of salt. You should not rely fully. At the same time, you cannot deny out. Okay, so whenever you are starting, just ask when the symptoms are started, what has started before the onset of coma, and how you expect that the patient is having some kind of problems, and what is the time course of disease, whether the patient will be improved immediately or it will take little time. That kind of details we have to discuss from them, and we have to assess properly, and then the patient can be shifted. Before shifting the patient to an ICU or ward, you need to take a proper history, as I already told. This is another clue where you can do it as a ample. Okay, ample is nothing but what is the allergy, what are the medication, any past illness or pregnancy, or if patients can be having some kind of last meal events or environment. These are the component. When we put all together, we get a ample history. Okay, and do a proper head to toe examination. Okay, so this is the case. Actually, this patient, the relatives brought to the emergency room saying that sudden onset of altered sensorium and very restless and aggressive behavior, and now he is not speaking. He is just rolling in the couch. Okay, when I examined, the patient is having a subconjunctival hemorrhage. What could be the cause? Any answer? Any answer, please?
Can be high blood pressure, sir, but the
High
age
blood
is
pressure. Okay. A good
Hep-
guess. Any other?
hep-
Pardon?
hep- Hepatic encephalopathy.
I couldn't get you, ma'am.
Hepatic encephalopathy. Maybe.
Petechiae encephalopathy. Okay. Bleeding, some kind of bleeding disorders. Okay. Somebody has put methanol toxicity. Okay. Any other better clue? This
Lyme's
is,
disease.
huh?
Lyme's disease.
Lyme's disease, Lyme's disease. Okay. Not
Cerebral
exactly.
malaria.
Cerebral malaria.
Malaria.
Okay. Okay. Why you come to a conclusion cerebral malaria?
There is rash. There is anemia.
Hmm.
Cyanosis
Breathing
is also
disease.
there.
No, no, no.
Hypoxia.
What type of
Actually,
rash?
no, no, no. Actually, I'm telling you have to look in the skin for rash, anemia, cyanosis, and jaundice. Not this patient has.
Okay, okay. But there is
But
hemorrhage, no?
the mother was the bystander. She didn't tell that the patient is having some kind of fever. Patient is apparently normal, suddenly became like this and became unconscious.
Dengue.
Dengue. Okay. Any better clue?
Uh, Subarachnoid hemorrhage.
Subarachnoid hemorrhage. Okay. Leptospirosis, DHF. Hmm. No? So
as,
this comes
aspirin injection
aspirin.
or
Why
clotting.
this young chap taking aspirin? Any collaborative evidence or any collaborations? No
blood
leptospirosis, no scrub typhus,
blood thinners, sir. Any blood thinners
blood
maybe.
thinners. Exactly not. Hanging. Kitna. How you came to a conclusion this hanging? Yes, ma'am.
Any type of seizure, maybe. Drop attacks.
Mm-hmm. Actually, Kirtana is correct. It's a case of hanging. So you can see Okay, this is a ligature mark. Okay, this is a ligature mark. Hmm. Actually, mother said that no, my son didn't hang anything. Suddenly he was found like that. She was telling because this is very common in the rural area. Because hanging, we have to inform to the police. They don't want to get into the police. Okay, so when you do a head to toe proper examination, we can be able to identify. Okay, this is a classical ligature mark. Okay. So in a coma patient, you have to look for any tongue bite in a case of seizure, neck hang mark like this, or any self-inflicted wound. See, though sorry for the poor quality, and you can see this is a tongue bite. Okay, tongue bite is very common. This will tell you whether it is a seizure or not. So once you look for this kind of visual clue, then you assess for the brainstem function, motor function, and respiratory pattern. Okay. So brainstem function, how you assess? You do a pupillary response, corneal response. Is there any spontaneous eye movement, reflex eye movement, or oculo reflex movement can be sorry. Reflex movement we can see or look for any doll's eye movement or oculo vestibular. There is a caloric response can be seen. How many of you are familiar in doing a doll's eye movement? Yes, please.
Yes, sir. Moving an object from right to left and left to
Hmm?
right. Patient's eye, one end to the other end of the head.
Hmm. How common you do this? In all coma patient you do
No, sir, only in coma patients we do.
yeah, ma'am, that only. All coma patients you do all same movement or any specific indication you have.
Mm.
We do in all coma patients we have to do Dolce movement. Okay. The pupillary response will tell you whether what is the location and where the lesion is there. Okay. The lesion above the thalamus and below the pons. Patient will have reserved pupillary reactions. They will not have a dilated or constricted pupil. They will be very normal. Okay. In case of toxic or metabolic cause, the pupillary response will be a mid dilated like that. It is not exactly having certain clues for that. This is one of the beautiful paper describing about the neuroanatomy and other structure. We can see in a small, okay, it's very small, that is 1 to 2 millimeter of millimeter, and patients having a reactive pupil, then it is a diencephalic. If it is a mixer mid portion fixer, the patient is not reacting, then it is a midbrain involvement. If there is any large fixer, then you have a tactile. Fixed or dilated pupil, then it is a third nerve palsy. Pinpoint pupil, that is a pinpoint pupil can be seen in pontine lesions or any pontine infarct or hemorrhage or whatever. So these are the non-structural area where the coma have some kind of collaborations or references can be taken from here. So normal reflex movement that implies the midbrain to pontomedullary junction intact is called as ocular movement. So when you ask the patient to look up, down, side, and to the tip of the nose, the paper is able to perform, then it means patient is having a normal ocular motility. So here the patient will not have any other difficulty in achieving it. So spontaneous eye movement, they can be a rolling eye movement, okay? They are called as very slow, conjugated, lateral side, and to and fro movement will be there, but it can be executed. Okay, the brainstem is normal, it means. So always when the brainstem is normal, always look toxic and as well as metabolic as your one of the differential diagnoses. The bilateral hemisphere that causes coma has been also accepted. The eyes look towards an hemispherical lesion and away from the brainstem lesion. This is one of the very important. So whenever you examining the patient in the eye, the patient having an towards you, that means the patient is having a hemisphere lesion, or if the patient's eyeball is looking outside or looking above, it means that patient is having a brainstem lesion. So just you look for the horizontal gaze palsy. So actually, this is a case of snake bite going for a brain death, and then we brought him back. Okay, how we are having a confidence in treating this patient? Because most of the time we are checking only for the doll's eye movement, that is your horizontal gaze. In case of OPC, snake bite, or central nervous system injury, this oculomotor nerve will not work. Okay, this will be blocked because of lack of nutrition and perfusion. So this will slowly get once the shock is reverted. So eye deviation in the resting position, it is a very poor localizing sign. Brainstem, bilateral thalamic, metabolic encephalopathy can be a cause for this downward. Or if it is looking totally downward and the puja has been done the time, so the poor localizing signs in sleep or in the seizure or brainstem lesions can be there. You can see the downbeat nystagmus. It is a CV junction mass. You can see how. Can you able to appreciate the nystagmus? See, this is a onto midbrain junction where the patient can see down is not there. See, classically you can see the nystagmus. So there is another thing called as ocular bobbing. Okay, the diagnostic of bilateral pontine damage because of thrombosis of the basilar artery. This is one of the nightmare for the treating patient. This kind of picture the patient will have a ocular bobbing. You can see this is a ocular bobbing coming little and going up, coming little and going up. So this is a the bobbing. So Dawes eye movement, it is when the head we move passively, we observe there is some kind of movement. So the eye should move conjugatively in the direction opposite to the movement. When there is an abnormal response, it indicates that the patient is having a brainstem diffuse. So whenever there is a trauma or the patient is wearing a collar, then don't do this doll's eye movement. This will further worsen the condition. So in the doll's eye movement, otherwise called as oculocephalic reflex where the eyes to the right are this is a normal, that is a central, and the head to right, then the eyes to be on the left side. So just imagine this: the patient is lying down, and the patient is pupils are in central. It means indicate that patient is having a normal response. If the pupil are suddenly becoming a right to left, then it means that the patient is developing a cerebral edema. Or if the patient is having eyes to left, then it will tell you that the patient is almost coming down. You can see this is a doll side movement. This is how we check for the corneal reflex. You can see the voluntary movement of the corneal. Okay. So another one important thing is caloric response. Very commonly nowadays performed in the ICU, and the ICU team comes from a public corporate hospital, and they want to ship the patient out for the harvesting. The doll's eye movement are absent, then you have to proceed for the caloric movement. In an ice water applies to the tympanic membrane, normally elicit a slow conjugated deviation to the irrigated side. So ice cold water on the same side, and absence indicate that there is a brainstem dysfunction. Left, when you are doing it, it more looking towards the right side. So the caloric testing is more sensitive than the oculocephalic response. And whenever we are there, we need to check for the tympanic membrane, whether it is perforated or not. If it is perforated or it is not indicated, then it means that the patient is having an intact TM membrane. Just see, leave a small feeding tube into the ear. So once this is over, we have to look for the motor function. Motor function, we have to look for any motor response, deep tendon reflex, muscle tone, and plantar function. So if there is an hemisphere, or if it may be a subcortical lesion, we can know that in case of hemisphere lesion, we can see there is a weakness, and whereas in a subcortical lesion, you will see a weakness with the deformity. Okay, if it is a midbrain upper pawn, okay, then the patient can have a Porter's tip hand, or like that the patient's hand will be turned to the opposite side. Whereas in a lower pontine or in the medullary region, then the patient can have a flexing of the knee. So another one important thing is myoclonic jerk and epilepsia partialis continuata or seizures. Okay, the myoclonic jerking is commonly seen when the patient is having an anxious and the patient is toxic or metabolic disorder. So the patient with brainstem herniation can have a both flexor as well as extensor posture triggered by the respiration on the external stimuli. They should not be confused with the seizure. Please remember. See, this is how the myoclonic jerk will be there. So you can see the jerk. This is post cardiac arrest, and then the patient improved. So please don't forget to do a fundus examination, all coma patient, and or the CT reported as a normal. anytime we are seeing the fundus is having a papillary. So, in case of any CVT, or the patient is having an hypertensive encephalopathy, or the patient is having a lead poison, methanol poison, or hypoparathyroidism, then we have to correct it accordingly. So, you can see the fundal examination and know that there is a blood leak. It will tell you the hypertensive encephalopathy, and by treating this, the patient will. So, now the clinical anatomical correlation in coma. So bilateral hemispheres are damaged and then dysfunction is there, or it is damaged or partially damaged and dysfunction. Yes, it is as per the rule, we have to treat it as a coma. Symmetrical sign, or the patient is having any seizures, myoclonic or brainstem reflex are normal, then we can perform this. The supratentorial mass lesion with the secondary stem compression. Okay, both brothers are there. They were doing almost similar work. He is in um, nearby place. Then another one is there. So any supratentorial mass lesion with the secondary brainstem compression, and you have to look for same side third nerve palsy or opposite side hemiplegia. So in case of brainstem lesion, the early eye movement will be having some kind of problem. The patient will be telling you whether he have to check for the specs, or already the patient is on glass. Then they would have gone check for the power, and then they will try to change. Actually, it is not exactly to change the glass. It is the patient has to be treated for knee stroke. The structural lesions may present with coma, can have a focal signs or without focal signs, or the patient can have some kind of meningism or can be a meningitis. Okay. So multifocal structural pathology are like cortical venous thrombosis or bilateral SDH, or the patient is having some kind of vasculitis or viral encephalitis. These are the reasons where we need to properly localize. See, this is a picture. Any guess what is this?
Subdural hematoma.
Subdural
Hematoma.
hematoma or hygroma? Yes, you are right. It is subdural hematoma.
It's right
But
around 24
most of the time, then there may be in older people because of cerebral hypertrophy. You can see a cerebral hygroma.
Yes, sir. Yes,
Okay,
sir.
this is a chronic subdural
Subdural
hematoma.
hematoma.
Why it is? Because the color is not bright red as
Right.
is seen in the bone. Okay, so it will be over a prolonged period. The heme which is in the blood will get oxidized, and then it becomes a different color. There are certain metabolic or toxic causes like hypertension, encephalopathy, hepatic encephalopathy, or hypoglycemia, or can have some kind of focal findings. So, hypoglycemia, what kind of focal sign you will expect?
Much in tachycardia.
Hmm? I'm asking a focal localizing sign in the central nervous system, not your tachycardia, bradycardia, hypertension, or hypotension. Sweating, seizures, not neurogenic symptoms. I'm telling you focal. Focal means some kind of structural damage like that. It will mimic, and once the hypoglycemia is corrected, it will settle. Plantar reflex, not exactly.
Patient won't be able to speak or less eye movements will be reduced, sir.
So initially, a patient was not able to speak properly. Some kind of slurring of speech was there. Hypoglycemia is a mimic for a stroke. So whenever you see a patient with a weakness, first you have to rule out
Yes.
hypoglycemia. Then only
You
you
know,
have
with
to.
stroke and as well as Bell's palsy sometimes it's
Can
just
be
like
a girl's palsy. Yeah.
yes.
So that is the first DD. Okay. That has to be considered. Hmm. And hepatic encephalopathy.
Confused, agitated.
You are not understanding my question, ma'am. I'm not asking any symptoms. I'm asking sign.
Aesthetics.
Aesthetics. So a patient is lying and patient is comatose. How you do a aesthetics or a flap?
Deep jaundice.
Deep jaundice is there. Patient can even cerebral malaria can have a deep jaundice. He's right. We need to check for the flap. How will you check a flap in a patient with the lying supine and patient is not able to uh, obey my commands? Is it possible to check the flap?
No.
Then how? How I'll come to a conclusion without doing any investigation? This is hepatic encephalopathy.
The hand can be stretched passively. It can be stretched, and the finger with finger spread, we can try it.
Not exactly. I will show you in a later slide.
Ocular
So
movements. Ocular movements.
ocular movements. Okay. I'm more interested in ocular neurology. Yes, movement will be there. Some kind of nystagmus will be there, but still specific to hepatic encephalopathy is your flap. So I'm not able to do a flap in a patient who is lying down, not able to sit. Okay, I will show you something. The periodic assessment saves you and your patient
Extensor
for
plantar.
plantar nodule. Okay, I'll come to that. I'll show you some odd one and also some classicals. Okay, so in the patient who is being admitted under you and the patient sensorium is gradually decreasing and the patient is having slowly dilating. I don't know how much you people have been appreciated this. I've seen many times patient suddenly go for a admission and the patient just 10 to 15 minutes or half an hour before patient would be reacting. Then slowly it became oval and then eccentric and then it will be fully dilated. So suddenly there will be change in the respiration. Okay, and the presence of Babinski sign. Okay, so you cannot sit next to the patient. So in an ICU, trained staff nurse, critical care staff nurse can be trained how to assess the neurological state in a periodic interval, especially in a coma to rule. Okay, whenever there is a slow deterioration, it means that the patient is in metabolic coma. Okay, except multifocal lesions like vasculitis or patient's seizure because of PRES, okay, posterior reversible encephalopathy syndrome, or the patient having some kind of SOL, may have a very slow progression. Otherwise, vascular will be very fast. Again, it is waxing and waning. This is a metabolic and importantly, recurrent embolic. Okay, or the patient is having some kind of demyelinating disorder where they will have waxing and waning of the sensory. So the normal reflex eye movement is again you see a proper eye movement will be there, doll's eye movement will be there, the corneal reflex will be there, pupil will be 2 millimeter or 3 millimeter equally reacting. Okay, and most of the time this will belongs to metabolic form. In metabolic coma or in a toxic coma, if the patient is taken phenobarbital or phenytoin, the pupil will be dilated. Looks like a brain stem dysfunction or brain stem death. Patient will have a pupil dilatation. Only breathing will be there. Then you have to rule out phenobarbital overdose or phenytoin overdose. Whenever there is having a small reactive pupil, then think of metabolic coma, except methyl alcohol. Okay, in methyl alcohol it will be dilated, and in datura also it will be dilated. Both condition it will be fixed. It will not react. Okay, so roving eye movement again it is a metabolic. Okay, in the myoclonic jug, if you see, it may be a metabolic cause or it may be hypoxia. So, as somebody told, you have to elevate the hand and say, "Hey, I'm doing this. I'm not able to elicit the tremors. See that flap, I'm not able to establish the flap. Whereas here, when you ask somebody to hold like this, see, you can have a classical flap. Okay. This has been classically described in EEG. Okay. So this is a classical flap. Okay. This we can see it in a patient who is having conscious. But in an unconscious patient, okay, or lying down, just hold your both ankle. You can see this is how this will go. Clear? There is something called as hysterical coma. Like that, the patient will be they will keep tight of the eye. They will not allow us to open the eye. So now moving on to neurological investigation, some CT is readily available, gives lot of informations. Don't directly jump for MRI. With the basic CT, we can able to rule out most of the causes. It's a raised ICP where you can see a narrowing of the third ventricle or any cistern is lost, then it will give you a clue of ICP. MRI, yes, whenever you think that there is a brainstem dysfunction, cerebral structures are involved, or any CVT or any compartment syndrome, then hypoxic encephalopathy, then we can think of MRI. EEG, it is very, very simple. Now, most of the hospital, they are having a bedside EEG also. Okay, acute, we can able to differentiate whether it is an acute, toxic, or metabolic causes, a sedative overdose, or any HSV, we can able to differentiate. Okay, see, it is a bedside EEG. This give you a lot of clues. This mostly match the toxic encephalopathy. Okay, this picture. So he is telling he has taken 10 tablets of diazepam. Okay, just this will give you a clue. So with this background, I just want to share you few slides for the time's up. A 23-year-old female, 50 tablets of alprazolam. Actually, she is a pharmacist having a shop. I was brought to the emergency room with the history of tablet were being empty strips were being spread around the bed, and she was found unconscious in the bed. And the ABC was stabilized. And one of my residents told that it's a pure alprazolam overdose, and I want to give flumazenil. He gave flumazenil. After giving flumazenil, immediately patient started throwing convulsion. Even the urine benzodiazepine was positive. Okay, so this is a ECG. Can you guess any clue from this ECG? Any guess? Actually, it is a TCA overdose. Okay, it is a TCA overdose. You can see lead area. Okay, lead area.
Okay.
So lead AVR and the QRS interval are widened. So most of the time history may mislead you. So you have to put all your details, history, clinical finding, ECG, ABG, and other investigation. Then we have to find out. So this is one of our paper where lead AVR we don't give more respect, but it gives a clue in the patient. Okay. Is another interesting case, an accidental fall in the bathroom, and the patient is engaged and going to get married in next 2 or 3 weeks. Okay, and she was very happy and went to today for the shopping for buying some uh, silk sarees and jewels, and came back and then went for taking bath, had a fall. Okay, and the patient was unconscious, then immediately taken to a nearby doctor, referred to a neurosurgeon did a CT showed SAH, okay, subarachnoid hemorrhage, and patient started having some frothy secretions, and then having a bowel and bladder incontinence, and then bradycardia was there. So they thought it is due to increased ICP and going for a neurogenic pulmonary edema, and the patient is throwing convulsion. Okay, and then patient was referred to us for further management. This is an CT brain. You can see subarachnoid hemorrhage. Any guess? Anything you want to interfere here? Am I audible, ma'am? Hello,
Is the,
audible?
is, yes, sir. Yes, sir.
Any guess? Anything you want to say?
Any herniation? Looking for herniation, sir.
Okay. Systems are not obliterated. Third ventricle is not squeezed. Subarachnoid is there. It's clear. So in emergency room, she was having 77% SpO2. So intubated, ventilated, started having frothy secretions. Pupils were 2 millimeter. When I did a sugars, it was 298. Heart rate is 48. You want to reverse anything in your diagnosis or any workup you want to add?
Ketones we have to,
Ketones. Okay.
and insulin drip maybe we have to
Insulin.
start
Actually, it is a case of OPC. Patient had a recurrent bradycardia. Meiosis was the secretion, so we did a pseudo. Pseudo was 453, started on atropine, patient improved. Okay. So always remember the toxidrome, avoid the distracting injury. Actually, patient had some quarrel with their fiancé and taken some OPC medicine, OPC, some few drops. Okay. As per our statement, it is just 5 ml of monocrotopaz mixed with the coffee and took and went to the bathroom. Accidental fall only. Okay, just accidental fall, and then had a subarachnoid hemorrhage. Meanwhile, the OPC started its action. So always remember the toxidrome, avoid the distracting injury. This patient saved. This is a 30-year-old male found unconscious, pinpoint pupil, profuse sweating, extensive rails, urinary incontinence, bradycardia is there. So we thought this OPC. We did a pseudocholinesterase. It was 543, but we couldn't able to identify any poison from the gastric aspirate. Any guess what could be the cause here? Yes.
maybe a farmer he must be while spraying he is
Okay. It's not a
Inhal
farmer.
Inhalation, sir. The
Inhalation.
condition.
Okay. Inhalation. Okay. Actually, he works as a malaria mazzoor, sanitary worker working in the malaria department.
Yeah.
Actually, we don't know what to do. So it is an intramuscular OPC. Okay, it is an intramuscular OPC. Always look for the needle mark. Okay, other routes. Okay, he is a person who was put his the nozzle in his rectum after applying a Vaseline and then started spraying, and patient he developed OPC symptoms. No clue, no needle mark, nothing. So then we treated him as OPC, and then once he became all right, he told that he had taken through the rectal. Then we did a colonoscopy. Colonoscopy showed a lot of diffuse necrotic patches. Okay, so we have seen even the bladder OPC. Okay, when we catheterize, you can see this kind of pictures. So always put tubes and fingers in all orifices in case of comatose patients. There's an 18-year-old female, again found unconscious, initially treated elsewhere. Patient is unconscious, pinpoint pupil, profuse sweating, chest clear, urinary incontinence, bradycardia was there. What could be the cause here? Fast. You are in the emergency room. Next cases are ready. Anything you want to do? Unconscious, pinpoint pupil, profuse sweating,
Give atropine.
give atropine, was
Please, hospital.
it is an organophosphorus. We thought, but pseudomonas is 8,600. 8,600. That is not OPC. Then what else? Will it be wrong? Pseudomonas will be wrong. So I thought it is wrong. So I sent it into a different lab. It again came as 8,400. Almost 8,000 is maintained. So it is not a case of OPC. So it is a case of Jatropa. Okay. So pinpoint pupil does not mean that only OPC and opioids. Especially in the tropical countries like us, we see a lot of Jatropa. It is nothing but a biodiesel plant. Government is encouraging all the farmers to plant for the biodiesel in the highways. Lot of seeds are there. Clonidine. Okay. Okay. Clonidine is important drug. Okay. Where we can see a pinpoint pupil. Amitas and xylazine is a veterinary drug. As we are in a rural area, we see a lot of veterinary drug poison, both amitas and xylazine. That also produce like a OPC, mimics like OPC and comes with the pinpoint pupil. Okay. Don't forget veterinary medicines. So the tribal way, so any unresponsive they eat. WWF, they make more unresponsive. Animal kingdom, easy meal. But as a physician, we don't make unresponsiveness more. What we do is we have to take care of airway, breathing, circulation, look for any disability, expose the patient, look for fundus, look, evaluate whether flumazenil is needed or not. Not all the patients needs flumazenil. Even in a mixed overdose, don't give flumazenil. Isolated benzodiazepine overdose only you have to give flumazenil. Look for all the G vitals, hospitalize this patient and then investigate. This is how you have to approach the coma. In an ICU, always beware of the second incident. Okay, I shown this previously because this is very important. Many times we will come to a diagnosis, what is the cause, but we will forget taking care of airway and breathing or circulation, or putting the patient on a ventilator, going for a VAP, sepsis, and then patient dies. So always look for the secondary accidents also. Thank you. Any questions? I am happy to answer.
Thank you, sir. Thank you.
Any questions? Okay, no questions. Thank you. Good night.
Thank you, sir.